So hello everyone, in this video I am going to discuss a very high yield topic for exams, which is approach to a patient with suspected pulmonary embolism. Now as we all know that pulmonary embolism is one of the major causes of death in hospital settings. So it is really important for us to know this topic. So let us start. I will try to keep it as simple as possible, and I will try to explain it, and I will try to simplify it using some mnemonics so that it is easy to remember for all of us. So first of all, if we are suspecting a pulmonary embolism in a patient, we have to start from a scoring which is known as the pulmonary embolism score, or also known as the Wells score. Now the Wells score is given in this table. It has 7 points. We can remember them with the mnemonics SHIT, MH. So let's start from it. The first point is that sign symptom of deep vein thrombosis. Sign symptoms of DVT, which is the very first point. And if there is a sign symptoms of deep vein thrombosis in the patient, then 3 points will be added to the score, which is the very first point of this scoring system. And along with this point, we can remember the second point also, which is another point: alternative diagnosis less likely than pulmonary embolism. Now, what are the alternative diagnoses that we should consider while suspecting pulmonary embolism? There can be myocardial infarction, there can be aortic dissection, there can be pericarditis, there can be pneumothorax. All this condition causes sudden severe chest pain. So if the other diagnoses are less likely, then further 3.0 should be added to the score. Now in H, we have history of DVT or deep vein thrombosis. History of deep vein thrombosis. So if the patient has prior pulmonary embolism or deep vein thrombosis, then we should add further 1.5 to the scoring system. In I, there is immobilization for more than 3 days or surgery within 4 weeks. So if the patient is immobilized for 3 days or more than 3 days, and if he has had a surgery within the last 4 weeks of the condition, then further 1.5 should be added to the score. In T, we have tachycardia. So if the patient has a heart rate more than 100 per minute, then further 1.5 should be added in this score. In M, we have malignancy. So if the patient have any kind of cancer, then further 1.0 or 1 should be added. And if the patient has hemoptysis, which is the last letter of the mnemonics, hemoptysis, then further 1.0 should be added. So we have covered all the 7 points. The first of all, sign symptoms of deep vein thrombosis. The second thing is alternative diagnosis less likely than pulmonary embolism. So for both of these cases, 3 points should be added respectively. And in H, we have heart rate more than 100 per minute. We have immobilization more than 3 days with postoperative conditions or surgery within 4 weeks. We have tachycardia, and we have hemoptysis. We have cancer, and we have history of prior pulmonary embolism or deep vein thrombosis. So after scoring according to this table or according to this Wells scoring system, if the score is more than 4 points, then pulmonary embolism is very likely. Say for example, a patient has a sign symptoms of DVT. He also has a heart rate of more than 100 per minute, and he does not have any other sign symptoms or any other history. So his score would be 3 plus 1.5, which would be 4.5. So it is more than 4, so pulmonary embolism is very likely in his cases. On the other hand, say for example, a patient has a cancer, he has hemoptysis, and he develops sudden severe chest pain, but he does not have any other criteria of this table. So his OLS score would be 1 plus 1, 2. So in his case, pulmonary embolism would be very unlikely because it is less than 4. So let's now focus on this table, which is actually the approach or the way we should approach a patient with suspected pulmonary embolism. So first of all, we have to do the OLS score. If the OLS score is more than 4 points, then we have to do the gold standard test for the pulmonary embolism, which is CTPA, which means CT pulmonary angiogram. So it is basically a CT scan which also sees the blood vessels. It's an angiogram, right? So it does two things. It sees the blood vessels or the pulmonary, especially the pulmonary blood vessels, and it also sees the lung field. So it serves us two purposes. First of all, it helps us to identify the size and the extension of the embolism if it is present. It also helps us to see the lung field and thus exclude other conditions or other differential diagnosis. So immediate computed tomography pulmonary angiogram should be done, or what we can do is we can start interim therapeutic anticoagulation while awaiting for the CTPA. If we do not have CTPA immediately available, then we have to start anticoagulation therapy and wait for the CTPA. If the CTPA or the CT pulmonary angiogram is positive, which means that if the CTPA shows that there is a definite embolus in the pulmonary vessels or the pulmonary vein, then the diagnosis is confirmed and we have to continue the treatment of pulmonary embolism. If the CTPA is negative, then we cannot discard the diagnosis. We have to look for deep vein thrombosis. Deep vein thrombosis is the major source of this embolus that dislodges into pulmonary vein and causes pulmonary embolism. So if deep vein thrombosis is suspected, then we have to perform a proximal leg vein ultrasound. So if we do a ultrasound of the leg vein, then it will allow us to see if there is deep vein thrombosis there, and it will allow us to assess the risk of that patient having a pulmonary embolism in near future. If DVT is not suspected, then we do not have to give any treatment. We do not have to give anticoagulant, and if anticoagulant was started, we can stop that and we have to think about alternative diagnosis. But if DVT is suspected, then we have to carry on the anticoagulation therapy in these cases. So all of this is when the Wells score is more than 4 points, which means the pulmonary embolism is likely according to the scoring system. Now, if the Wells score is less than 4 points, then pulmonary embolism is unlikely but not impossible. Okay. So what we have to do is then D-dimer test. Now, D-dimer test allows us to have an idea whether the patient is having pulmonary embolism, but D-dimer is also raised in many other conditions like myocardial infarctions and many other conditions. So D-dimer is not a definitive diagnostic point, but a negative D-dimer allows us to discard the diagnosis of pulmonary embolism. So if the D-dimer is negative, then we can say if the D-dimer is negative as well as the Wells score is less than or equal to 4 points, then we can safely say that the condition is not pulmonary embolism. So we can stop the anticoagulation therapy and we can think about the alternative diagnosis. But if the D-dimer result is positive, then we have to consider pulmonary embolism again, and then we have to approach like we did before when the LC score was more than 4, and we have to do the CTPA. We have to wait for the CTPA result. Then if the CTPA is positive, we have to start treatment for pulmonary embolism. If the CTPA is negative, we have to consider looking for deep vein thrombosis and continue treatment for that. So another important point is, as we wait for the D-dimer result, anticoagulation should always be continued. Now, whether we should continue the anticoagulation therapy further depends on all these diagnostic criteria, which we will discuss in another video as a part of the treatment of pulmonary embolism. But I hope that in this video I have been able to give you an idea about how to approach a patient with pulmonary embolism. This is a very high yield topic for many exams, and I hope you enjoyed the class. Thank you very much for joining me.